Hello everyone, today we have a few different cases for you and a little bit of a different setup from what we do normally. We're going to talk about invasive ductal carcinoma or invasive carcinoma of no special type. So these account for 3/4 or 75% of all invasive breast carcinomas, so they're actually very common when we consider invasive breast carcinoma. They're also known, as I said, carcinoma of no special type, not otherwise specified, or you may even hear them called mammary carcinoma. Almost 100% of these are going to be women. You might have one or two out of the 100 that will be male, and the average age of diagnosis overall is about 60 years old. Less than 15% of your cases are going to be in younger women, and when we say younger women in breast cancer, we mean younger than 44, 45 years old. There is some slight differences with regards to what type of invasive ductal carcinoma we're looking at. If we're looking at hormone positive, so this is our estrogen and progesterone receptor positive, which is what this case is, there's a bimodal distribution where you'll see peaks at 50 and 70 years old. Pardon me. So as I said, this is an ER positive breast cancer. We also will call these luminal type. This one in particular is a luminal A. And what's luminal A? What's luminal B? I know this is a topic that can be somewhat confusing as I switch to 4X here. So luminal A basically means that these are the lower grade tumors. So these are grade 1 to 2 tumors. They will be ER, PR, or at least ER positive, HER2 negative, and they tend to have a low Ki67. So all this in keeping puts you in the framework of this is luminal A. And why is this cancer? Well, we can see from this view that the stroma is a mix between this bubblegum pink, and then there are areas that are more slate blue or maybe a little purplish, depending on what you're seeing. And what we're actually appreciating is desmoplastic response around the carcinoma. So if I back up again to 2X, let me just get you guys in focus. You know this is carcinoma because this isn't a lobular arrangement, okay? It's rather haphazard. You have glands in places that don't really make sense. It's not round. Now there is some DCIS mixed in with this case, so you kind of have to ignore that for the purposes of this talk. So we're going to go into an area that definitely is more invasive. Okay, so going up to 10X now. Why is this carcinoma? Well, again, we're not seeing definite ducts. You can appreciate that around the areas where we have the cancer cells, there's no myoepithelial layer. And what the myoepithelial layer is a second layer that you would appreciate in areas of DCIS, okay? And that's the definition of in situ, is having that myoepithelial layer intact, okay? When we're grading these, I did say that they are low grade, and we will go in detail about the Nottingham stage and the modified Richardson-Bloom of the Nottingham stage. But basically with this one, I'm looking at overall, if this is indicative of the entire tumor, which it is in this case, we are looking at between 10 to 75% of the lesion is forming tubules, so that gives it a 2 for tubule formation. The nuclei aren't overly irregular, so you could go either 1 or 2 for the nuclei. I've seen different thresholds for things, and there's not very many mitotic figures in this entire lesion, so your mitotic figures on this case would be at a 1. So whether you went 1 or 2 on your nuclei, depending on your personal threshold, your institutional threshold, this is going to be 5 or less, okay? And that's going to make it a grade 1. So this is a grade 1 tumor. And these are very good for luminal A. Luminal B may or may not have HER2 positivity. They tend to be higher grade, so that's when you're looking at grade 2 to 3 tumors instead of grade 1. Let's see if we can go to a different area. So you can see here, like here's more luminal response where you can see little tubules forming. and a little less of the desmoplastic response. Your luminal B, as I said, will be HER2 positive, may or may not be HER2 positive, sorry. They tend to have higher mitotic activity and they tend to be higher grade, so those will be grade 2 to 3 most often. If you're looking at HER2 positivity, we'll go back to our 2X. We can get you guys in focus. This is a HER2 positive tumor, hormone receptor negative. Okay, so this is a HER2 tumor when we're looking at if you ran like a mamma print or something like that on this. So what we see that's different in this lesion compared to the first one is that it's less clear if it's really trying to form tubules. That's the first thing you see at low power. If we go a little higher, get in focus, we can appreciate that desmoplastic response even more in this case. There's a lot less of that bubblegum pink around these areas, and the tubule formation that is here is very angulated, right? There's some areas that are round, but the bigger glands tend to be very sharply demarcated and angulated, and it almost seems like things are falling apart or falling away from this lesion. Okay, so again, on this, you're between the 10 to 75% tubule formation, so I would give it a 2 for that. Let's take a look at some nuclei. So what we notice right away is that compared to our previous lesion, and we're only at 10x here, there's a lot more irregularity with our nuclei. Okay, we have some big ones, some little ones. I'm already starting to see some mitotic figures. So for me, I would be at least a 2 based off of these few fields for nuclear features. Okay, we don't have everything looking the same. There's definite anisonucleosis with this, so or different sizes of the nuclei, different shapes of the nuclei, so you want to account for that. The mitotic activity is also higher here, so it's not crazy high, but it is higher, because it's like even in this field I'm seeing a few different mitotic figures. So I'd be at 2 for tubules already, 2 for my nuclei, and I'm already going to be probably at a 2 for mitotic figures. Now, depending on what you see in your high-powered fields, and remember that your the amount of mitotic figures you see does change depending on the field within your microscope. Okay, so that's something that you do need to keep in mind when you're evaluating mitotic figures in breast cancer. So 2, 2, 2, that puts us at a 6. 6 is a grade 2, so this is a grade 2 tumor. Our HER2 positive tumors, which is what this is, do tend to be high grade, okay? So they do tend to be grades 2 to 3, and what's interesting about these is that even though they are HER2 positive, the HER2 can be heterogeneous in this. So what that means is that, and I've seen this in quite a few cases where the lower grade aspects of the tumor may actually have the HER2 positivity, and your higher grade areas might be negative for HER2, or vice versa. So you do have to keep that in mind. You do have to evaluate carefully your HER2 and make sure that you are evaluating tumor as well. Like, you don't want to be looking at your DCIS and stuff like that, okay? Your invasive tumor is what you should be evaluating. And again, with this, we're only seeing the single layer of malignant epithelial cells. We are not seeing myoepithelium. Okay? So here is your HER2 positive grade 2 tumor. Okay? And the final area that we look at, and I have a couple slides to show you on this case, is our triple negative basal-like tumors. Okay, so these tumors, as the name states, triple negative, so they are hormone receptor negative, HER2 receptor negative, or just HER2 negative, and they tend to be high grade. Okay, so looking at this core, it's very difficult to tell that you're even in breast. Okay, maybe if you get to this stuff, I'd be like, oh, okay, well now I see that I'm in breast because towards the mid left of the screen we have normal ductules, but here, this is tumor, okay? The desmoplastic response, maybe not quite as appreciable as some of the other cases, but here, this is less than 10% tubule formation, okay? You can argue that, okay, well, there's a couple tubules towards the top of the screen that are maybe trying, but all in all, this thing has just given up. It's laid down. It said, I've had enough. I am not going to try and form tubules anymore. I mean, look at this. When we talk about syncytial formation, sheet formation, this is what we're talking about. And you can appreciate how sometimes ductal carcinomas, or carcinomas of no special type, can be mistaken for, is this lobular? There are areas where it is tracking in single files, there's single cells. Okay, so you do have to be wary of that. If something smells like ductal formation, it's probably ductal. Okay, and as we go through here, we kind of see similar things that we saw with others. So we have basically no tubule formation. So we are at a 3 of 3 for tubule formation. These nuclei are all over the place. We have different shapes, sizes. There's really no two that look the same, okay? So this, for me, would be a 3. And, you know, for 3, you also have to have like enough anisonucleosis, but I think that this would make it. This is a biopsy, so you do have to keep that in mind as well. But so for nuclei, even if you went 2 or 3, that's fine. And mitotic figures, heck yes, we have lots of them. If we go up here, we are at 20x. So I see 1, 2, 3. I know I saw a few over here. There's one. I think if I actually tried to do 10 high-powered views on this case, I'm going to be at least 5, if not between 5 to 10. I might even reach over 10. And obviously the point of these videos is not for me to sit here and count mitotic figures with you, but whether we're looking at this is a 2 for mitotic figures, or 3 for mitotic figures, or 2 for nuclei, or 3 for nuclei, this is, to me, this is a grade 3 tumor. I can't justify calling this a grade 2 tumor. It's too much. I want to give it a 3 for those nuclei. I mean, like, look at these guys. These are scary. Scary. So we have 3, 3, and at least a 2. So we are looking at 8, and 8 and 9 out of 9. Those are your grade 3 tumors. Okay? But again, I can appreciate how sometimes these can look like lobulars, so you just have to go down and look for the features that tell you this is unlikely to be lobular because it doesn't have things like the intracytoplasmic mucin that you would expect to see. You could do things like your E-cadherin and stuff like that, but your morphology more often than not will help you. The other slide I had to show you, since this case actually had a couple of spots, has a feature that you should mention when it's prominent like this. And some of you are probably crying out already what this is, but this is necrosis, okay? And when we look at the actual tumor, this biopsy has more of a desmoplastic response. But you can still see that we don't have tubule formation, okay? But we do have a lot of necrosis. So that is something that you do want to mention in the biopsy. This is a separate site, so you would want to say on this particular biopsy, invasive ductal grade 3, with necrosis, okay? Because this might be something that they're seeing on imaging that can help explain their findings and help make it concordant, okay? So this is a very aggressive looking triple negative, invasive ductal grade 3. So again, these are hormone receptor negative, ERPR negative, they are HER2 negative, and they tend to be high-grade tumors. When we're looking at molecular for all of breast cancers, okay, not just triple negative, all of them, your BRCA1, BRCA2 are going to be associated with the highest inherited risk of developing breast cancer. You also need to consider multiple other genes, and some examples of them are TP53, P10, CHEK2, STK11, ATM, PALB2. There's lots of different lesions that are associated with increased risk of breast cancer, that have familial risk. You know, there's lots of things to look into, and I encourage you to take a look at the NCCN guidelines, which are updated regularly, to decide whether or not your patients need to go for genetic counseling and maybe have some of these genes soothed out. Your differential for invasive ductal, okay? If we go back to some invasive ductal. Man, this is a scary tumor. That is scary. Okay, so your obvious differentials are going to be things like, is this carcinoma in situ? Is this ductal carcinoma in situ? Well, invasive ductal is not going to have myoepithelial cells. How do you find that? You can do your P63, you can do SMA or smooth muscle actin. You can do smooth muscle myosin heavy chain or SMMHC. And remember, as in the first case I showed you, there can be DCIS intermixed with your invasive carcinoma. Obviously, your invasive carcinoma is going to be the most important finding, but you do need to mention the DCIS, particularly on resections, okay? You could be wondering, is this maybe like a radial scar? Is this a sclerosing lesion? So radial scars will have a central nidus, which you should not see with this. Although, again, invasive carcinoma can involve anything, but if you were considering, is this radial scars have central nidus, and they don't tend to have a desmoplastic response. They have a prominent hyalinization of the stroma, okay? So everything should look bubblegum pink, okay? And that just becomes more and more prominent the more chronic those lesions are, the longer they've been sitting. Sclerosing adenosis, similarly to radial scars, will also not have a desmoplastic response. And what sclerosing adenosis really likes to do is it likes to swirl around benign ducts, okay? So you'll see this swirling, whirling pattern. You do have to be careful, though, because if you recall from our unknown session on epithelial lesions, is that sclerosing adenosis can show perineural invasion, okay? So you do have to be careful with that. Let's just go back to the grade 2 ductal so you can look at that while we keep talking about differentials. So back at the grade 2. Okay, other things to consider, and this is probably very timely. You can think about microglandular adenosis, or MGA. Terrifying lesion, right? So microglandular adenosis does not have myoepithelial cells. So if you were thinking, oh, I'll just throw an SMA or a P63 on this and this will sort it out for me, that's not going to help you with MGA. However, MGA should not have a desmoplastic response at all. Even though the glands may look angulated, they may look really sharply demarcated, they may, they will be haphazard. So it could look very similar to this, but you will not have a desmoplastic response. The other thing that can help you out with MGA is that microglandular adenosis has these intense eosinophilic secretions, material in the lumen. So that is something that can help you out, because invasive ductal carcinoma or carcinoma of no special type does not have that eosinophilic material, okay? If we're looking at all the lumens, all the little punched out areas in this lesion, they're empty. There might be some that have some lightly pale material in there, some like non-specific material, but we're talking intense eosinophilic material for MGA. Other things you could consider, and this would be particularly with your grade 3, so with lesions that are falling apart, you need to think about things like lymphoma, or is it sarcoma, is it a metastatic lesion? We're just going to go back to the grade 1 lesion. So here you can see there's some of the in situ component, there's a little more of it. And just going back. So you can see again, this is our grade 1 lesion. Okay, it's a low power. So obviously if you're thinking lymphoma, sarcoma, metastasis, whether it's a melanoma or anything like that, sorry. So you can appreciate the regularity of these cells a little more. We'll even go up to 20x here and try to get you in focus. Okay. All right, there we go, in focus. Treatment for all these is going to be kind of dependent on what the patient wants, what's the extent of disease, etc. So whether they do a lumpectomies are typically followed with radiation. There may or may not be hormonal therapy, chemotherapy. They could try immunomodulation. There's lots of things that they can try. If the patient goes for a mastectomy, it would have to be extremely extensive disease in the lymph nodes, or like really close margins that they couldn't resect anymore for them to be aggressive and going with radiation. Usually mastectomy means they're not going to do radiation, but not always. Okay, there are instances where they would still consider that, and again, they'd still also look at, is this patient appropriate for chemotherapy, hormone therapy, all those kinds of things. So what you have to kind of frame in your mind when we're looking at all these is that if you have hormone positive, so ER/PR positive, that patient may respond to hormone therapy. If the patient's HER2 negative, you're not going to give them a HER2 targeted therapy. And simultaneously, if they're hormone receptor negative, you're not going to give them hormone therapy because it's not going to respond to that. As far as prognosis, your luminal A will have the best prognosis, right? These are our lowest grade tumors. They tend to be hormone receptor positive. So depending on the size and situation, the patient might not even necessarily go for surgery. They might just do hormone therapy. And again, it's an entire menu of options that will be discussed with multiple clinicians. And then traditionally, your basal-like phenotype or triple negatives tend to do poorly. They tend to be poor actors, simply because it can be difficult to get something that works really well with them. But these patients do tend to respond best to like neoadjuvant chemotherapy. So just because you have one diagnosis over the other, or you're saying this is a grade 1 versus grade 3, obviously grade 1 tend to do better than grade 3, but not always, and luminal A tend to do better than triple negative, but not always. So there's also different things that are going on in breast cancer treatment, lots of different trials. And this is just a quick snapshot to kind of give you guys a framework for figuring out your mammo print types, and as well as a little bit of grading. That's what we have for today. So if you like this video, please hit like. Please subscribe if you aren't subscribed. If you think this video would be helpful to others, please feel free to share this on social media. If you have things that I missed, things that are confusing, please let me know in the comments. And we'll see you next week with another short review.